Welcome everybody to LDI's virtual seminar on COVID-19 vaccines 1 year later. It's been nearly a year since the first COVID-19 vaccine was approved through emergency use authorization. And while at times it feels like we've made a lot of progress, at other times it feels like we have a lot of work left to do. So I'm very excited to welcome today's panel for what I know will be a great discussion on where we are 1 year later and where we need to go. So we have a really great lineup of panelists today, and I'm so thrilled to have them join us here. So I'm going to start with introducing them. So first we have 𝗦𝗘𝗘 𝗧𝗘𝗫𝗧 joining us, who is the U.S. Director and Strategic Advisor to the CEO for the Coalition of Epidemic Preparedness Initiatives. She's also the former Assistant Secretary for Preparedness and Response at the Department of Health and Human Services, where she led efforts in preventing, responding to, and recovering from adverse health effects of public health emergencies. We are also joined by Florence 𝗦𝗘𝗘 𝗧𝗘𝗫𝗧, an assistant professor of medicine here at Penn, who is a specialist in infectious diseases. She has been very active in efforts to engage with and provide support for communities of color impacted by the COVID-19 pandemic here in Philadelphia. Paul Offit is director of the Vaccine Education Center and professor of pediatrics in the Division of Infectious Diseases here at the Children's Hospital of Philadelphia. He is a member of the Vaccines and Related Biologic Products Advisory Committee advising the FDA. And we are also joined by Ayla Stanford, who is a staff pediatric surgeon at Jefferson Abington Health. She is founder of the Black Doctors COVID-19 Consortium, providing education, access, and advocacy in African American and underserved communities disproportionately affected by the pandemic. She recently opened a Center for Health Equity, which is a health center in North Philadelphia, providing preventive care and mental health services to reduce health disparities. Today's panel will be moderated by Allison Buttenheim. Allison is Director of Engagement here at the Leonard Institute of Health Economics, and she is Associate Professor in the School of Nursing here at Penn. She doing research on how to increase vaccine acceptance through behavioral interventions. So thank you all for joining us, and Allison, I will turn it over to you.
Thank you, Rachel. So it has been a year in every meeting of that. A year ago, we gathered a similar panel. In fact, Paul and Nikki were here, and we were just on the brink of the emergency use authorizations for the first vaccines and thinking about the rollout that was going to ensue. I think we knew it would be a wild ride, but I think there were also some things we didn't quite anticipate. Maybe the fall off the demand cliff in the US, at least in mid-April. All the different forms that vaccine hesitancy has taken and the ways in which that's driven disparities of all types. And then this interaction of global supply issues, variants emerging, and sort of the booster question. So all of those have created a really dynamic landscape for both the supply side and the demand side of this vaccine rollout, and really thrilled to have this group of experts here to talk through it. So I've got sort of a kickoff question for each of our panelists, and then we'll pivot to being a little bit more interactive. And again, we encourage your questions in the Q&A, and we will get to as many of those. We'll have more than we can get. So Paul, we're going to start with you. And I think, given your expertise, my question is around Omicron, the elephant in the room, the variant in the room, and how you're seeing that variant and other ones that may emerge, changing how we think about the protection that vaccines offer now and going forward. How should we be thinking about Omicron?
Well, I think we have to define what it is we want from this vaccine. I mean, if what we want from this vaccine is protection against serious illness, I mean, all the evidence is that we have protection against serious illness for the original variant that came into this country, 𝗦𝗃14G, as well as for the Alpha variant, the Delta variant, and likely we'll have that for the Omicron variant. Because protection against serious illness is mediated by memory cells, primarily memory B and T cells. And if you look at the so-called epitopes, the immunologically distinct regions for T cells, that really is conserved for this variant as well, for the Omicron variant as well. So if protection against serious illness is what we want, it is very, very likely that 2 doses of an mRNA-containing vaccine, for example, or 2 doses of the Johnson & Johnson vaccine will do just that. If, on the other hand, we want protection against mild illness or low moderate illness, which is mediated by neutralizing antibodies present in the circulation at the time of infection, that's different. And that's going to mean not just a booster dose, because I think it would likely mean more than a booster dose, one booster dose in the future. And I just think we need to get the public to understand that. I think, and I'll just finish with this last rant. I think that the mistake that was made, I think the communications error that was made occurred on July 4th of this year with the outbreak that occurred in Provincetown, Massachusetts, right? Thousands of men get together. There's an outbreak. 79% of them are previously vaccinated, say with 2 doses of mRNA vaccine. Nonetheless, there's an outbreak. So 346 men who had been vaccinated, fully vaccinated, developed COVID. 4 are hospitalized for a hospitalization rate of 1.2%. That's good. That's a vaccine that's working very well. The remainder had primarily asymptomatic or mildly symptomatic infection, which were unfortunately labeled breakthroughs. The term breakthrough implies failure and holds this vaccine to a standard that we hold for no other mucosal vaccine. If you have an asymptomatic or mildly symptomatic infection after being vaccinated, you won. I mean, that's what you want. But the term breakthrough created an expectation for this vaccine that I think is very, very hard to meet. And I think Omicron was used as an excuse to offer a booster dose. And by the way, I think booster doses should be given to those over 65, should be given to people who live in or work in long-term care facilities, arguably people over 50 who have certain medical conditions that put them at high risk of this disease. But otherwise, we have this sort of war against mild infection for young people that I think does not make a lot of sense to me. And I think at the very least, we need to explain to people what it is that we can reasonably expect from this vaccine. I'm done with I'll just one little rant addendum, which is I was on service last week and we saw a lot of patients with COVID. I mean, more than I'd seen actually before. They were admitted to the ICU. It was pretty grim. I can tell you what all those patients had in common, including most that were over 5. None of them had been vaccinated. They hadn't been vaccinated. Parents weren't vaccinated. Siblings weren't vaccinated. The problem here is not boosting the vaccinated. It's getting people to vaccinate, because we're not going to leave this pandemic until that. I mean, Rochelle Walensky, I think, got this right. She said, quote, "We're not going to boost our way out of this pandemic." But all the discussion now is about boosters. And I feel like it's in some ways a diversion.
Thanks, Paul. That's actually a great pivot to Nikki. You know, a year ago, you had a lot of good things to say about, insightful things to say about how the global supply would look, how we needed to think about the global supply. What's top of mind for you now, as we're a year later, about what we need to do globally to get through this?
Well, I think I would follow really naturally from Paul's comments. What's top of mind globally is getting the rest of the world vaccinated as quickly as possible. You know, I think what we've seen is probably not surprisingly, but disappointingly, high-income countries continuing to buy up and hoard a ton of vaccine, being really, really slow to release their hold on those doses to COVAX so they could be distributed elsewhere. When they are released, they're released with short time to expiry. They're released with almost no notice, so a country can't plan. And then we say, aha, countries can't deliver these doses. Well, we can't deliver these doses in the US either without advance warning and with short shelf life dates. So I would say we gotta get vaccine to the rest of the world, and we desperately need to accelerate it. I will say, however, that right now we are shifting from an environment, and I don't think we really anticipated the degree to which there would be all kinds of different export bans on vaccines. So I would say there was a huge mistake in over-reliance on India, for example, to be the source of vaccines, and the export bans, particularly of doses to COVAX, have been incredibly harmful and destructive to the global vaccination effort. I think now we're in a situation, however, where we're shifting from being supply constrained to being, let's call it demand and absorption constrained. And it's a really confusing situation out there. So countries have now a lot of different choices about what vaccines are out there and available. We're seeing many, many countries say, gosh, I no longer want XYZ vaccine. I really want an mRNA vaccine. Because that's what's being used in the US, or because of the perception of those vaccines, even though they've got cold chain issues and are expensive. And we're seeing, for all the reasons I just mentioned, countries say, well, I want to send these vaccines back because they're about to expire or do other things. The other thing that we've seen, and I think it's really worth calling out here, is we talk a lot about misinformation here and disinformation. It is a global problem and it is huge. And we talked about it a little bit, I think, last year when we started seeing, pictures generated by Russian media about the AstraZeneca vaccine turning you into a chimpanzee. The messages are much more subtle now. But the disinformation and misinformation is everywhere. Every country has its own brand. Every country has its own obstacles to overcome. There's not a one-size-fits-all approach to this. And we are already seeing now amazing disinformation machine already with Omicron, let alone the gargle with Listerine part, but now all the accusations that the vaccines that are out there have caused Omicron. So we've got a lot of challenges there to overcome. Having said that, we know that the vaccines that are available, they're safe, they are effective. We don't know how long the duration of immunity really is, but I think I am aligned with Paul in his view of this. And we're seeing a lot of really aggressive marketing by the vaccine companies under the guise of, hey, neutralizing antibodies are declining, and so we need boosters. And I think we need to find ways to moderate that. So I'll stop there.
Thanks, Nikki. Let me go to Florence and maybe zoom in on Philadelphia. You've really been at the forefront in helping the city think about an equitable rollout for this vaccine. How do you think we've done? You can give it a grade from A to F if you want. Are there lessons, maybe both positive and negative, that we can take away from our experience here in the city?
Yeah, thanks so much, Allison, for this question. So I think if I go back to the previous administration, I think we started out at a very, very low bar, and I would probably give it an F at that point, but think that we migrated to a better area. I think that there's still more work to be done. I appreciate the fact that what we've done better at is at being intentional when addressing disparities in vaccination uptake. Now, issues related to racial disparities are complex, and they are rooted in practices of structural racism, and it will take a lot of time and persistent intentional effort to move the needle toward equity. But I think that we can get there, and we already see the gap in terms of the racial disparities for COVID-19 vaccine uptake to be lowered, and they have lowered over time. I think what we've learned since the beginning of this pandemic is that using multi-level strategies is key. So what I mean by that is that we can't address the lack of access to COVID-19 vaccines without addressing vaccine hesitancy. And this is both valid for the US and globally, as my colleague mentioned already. And I think that we need to continue increasing access to free vaccines, particularly in communities that are under-resourced and where incidence is high, and to provide a vaccination at trusted and convenient places like schools, churches, and I think that's what we've done well over time in Philadelphia, including also providing vaccines at pharmacies and barbers and salons. And we need to continue addressing vaccine hesitancy by providing scientifically accurate messaging and using trusted messengers for this. And I would say that cost is something that we need to keep an eye on. The vaccine needs to continue being free to all individuals, regardless of immigration status. And while vaccination is a key pillar to COVID-19 prevention, I do think that testing still has value, particularly because a significant number of individuals have not been vaccinated. And testing and isolation still remains an important strategy to combating the pandemic. And what I see right now in the current landscape is that testing is either unavailable or costly, and I think we need to do better. So overall, I think that we have done better, but there's still a lot of work to be done.
Thanks for that. And that's, I think, a great tee up for Ela. Your work launching Black Doctors COVID-19 Consortium has been amazing. Your advocacy. I think, one message I've really taken away from your work is that this vaccine rollout, is only going to move at the speed of trust. And really curious on your reflections about how you actually bake that into programming, into public health systems, into private health systems and care delivery, so that we can serve all communities equitably.
Thanks for that, Allison. I mean, I think a big part, and you hit on it, is trust, but trust is earned, right? And you can't flip a switch to get it. And so in order to incorporate, for example, some of the things that we have done, that would take time. And so we started back in March of 2020. So by the time we got to vaccinations in January 2021, we already had 25,000 people, their families, their communities, their churches, and their circles that were spokespersons for us, right? Because much of that in the community is word of mouth. And it was more important for them to hear it from their pastor, their grandmother, than it may have been to hear it from their doctor, if they had a doctor. And so how you implement that, I think in an academic setting, is the providers need to reflect the communities that they serve. We know that doctors of color only represent about 5%, but the ones who are there need to be culturally competent. It should actually be part of the hiring process with new employees come in, that you need to know how comfortable you are in the environment. No one ever asked me that, but they certainly asked about my, board scores and where I ranked and all these things, but the emphasis hasn't been put on that. And these are the folks delivering care. The other thing, because I'm already beyond pandemic, I'm already thinking about, okay, while this light is shining, what are the other things? So you might look at your ER, you may look at what things people come back and they're readmitted for, and then you institute something in that community for people who come back for hypertensive crises, people who come back for, asthma, people who come back after surgery for wound infections. And you may find it's the same age, it's the same gender, it's the same ethnicity, and you focus on preventative care because it's honestly cheaper to do that than it is to be reactionary and for people to have continued admissions. And then finally, it has to come from the top down. The messaging has to come from administration to say that this is important in our hospital. It can't just be, sort of a phase. There was a study actually that came out from Robert Wood Johnson yesterday that said the emphasis on equity and COVID is already waning. People are already like, it was, but now it's all better, to the doctor's point prior to. So yes, we did do better, but all those locations that were available for testing and vaccinations, they're gone. Everybody thinks we've met our mark. I can tell you on Wednesday, we saw 187 people and 70 of them were for COVID testing and 15% of them were positive. So there's still a huge need out there. And I shouldn't have said finally, money. When you say something's important, you invest in it. It's not just for a grant. It's not just for a 6-month or 2-year period. It has to be sustainable for a lifetime. It needs to outlive us. And so right now, while the light is bright, what happens when we reach containment and all those folks are still having strokes in their 40s and 50s and colon cancer that's delayed in terms of diagnosis? And so I think it points to us as healthcare professionals and leaders to say, how do we prepare our next generation and educate our current providers that we can do better? Because no one intentionally wants to not provide good care, but I think we mistakenly think that they know how to do it in certain communities. And what I've learned over this past year is sometimes how we miss the mark. So trust.
Thank you. Let me pivot to an open question to all of you and jump in wherever you have thoughts. The policymakers have been asking for a year for evidence on what works. Tell us what works to get this rollout to be successful. We've been through lots of questions about what messaging, how do we message appropriately? And then, later in 2021, lots of questions about incentives. Should we be doing lotteries? Should we be giving people $25 gift cards? I think now a lot of the conversations are around mandates. healthcare workers early on, now, employers generally, maybe, in some countries, even national mandates. Would really love your perspectives on either and or the incentives question or the mandates question as strategies now to close some of the gaps on coverage.
Or I'll start, and I probably am the least informed actually here about this with Allison and Ayla and others, but I think that if you look at the varicella vaccine, which came out in 1995, the uptake for that vaccine was slow for the first couple of years. And then the company went to a much more emotional strategy. There was, I can't believe I lost a child to varicella. There were pictures of children who had hemorrhagic varicella. It was pretty grim, and they were criticized for that. But nonetheless, that actually did work, I think, to fairly dramatically increase rates. Here, what I would like to see, and it'll never happen, but I'll just throw it out there. Having experienced what I experienced last week at our hospital, it was really gut-wrenching. I mean, I wish I had a film of everything I saw, because what you saw is you saw children 5, 6, 7 years of age whose parents had chosen not to vaccinate. I mean, we've had a vaccine really for the last 6 weeks or so available to that age group. Or teenagers. There were a couple teenagers who came in. We've had that vaccine available for many months, struggling to breathe, terrible coughing, struggling to breathe on 3 liters of oxygen, 4 liters of oxygen, 9 liters of oxygen. And then they're wheeled up to the ICU with parents crying as we sedate the child, put a tube down into their trachea and connect them to a ventilator. See those images, look at those images, and then still choose not to get your child a vaccine. I don't see how that happens. Now, this is we see it a little bit with adults. We see that on television, not so much. But I guess what I'm arguing for is a far more emotional appeal. And I don't know what works, and maybe that doesn't work either. But I just wonder whether or not that would be of any value. But I throw it to you guys who are much more communication experts than I am.
Allison, I would jump in after Paul and say, I wholeheartedly agree. Every chance I get, I remind people that of the children who have died, 65% of them are African-American and Hispanic. And if you ask Dr. Offit, who's in the ICU, who did he watch those tubes go down? He'll tell you they were Black and brown children. And I emphasize that to folks that I see. I love the fact that you can walk in and get a vaccine at 12. I think it might even be 11 in Philly. And so we are right across the street from Dobbins High School. And at 2 o'clock, when they start getting out of school, they walk right over. It is the most beautiful thing to me to see the kids coming over together. Mandates work. We helped the school district of Philadelphia. We helped with the SEPTA workers. I did, educational sessions for them to come in, and most of them looked at me and they were pissed. They didn't want to hear any education session, but what they did know is they had to support their families, and they were the breadwinner. And this was about the livelihood of their family. And for them, that was motivation enough, which makes you go back to, you got to find out why they didn't want it in the first place. This whole preconceived that someone thought there was a chip or that people don't trust the vaccine, it just had to matter to you. So seeing someone you love get sick and die, seeing someone you love struggle, seeing someone not be the same after getting COVID, not being able to provide for your family, for the teenagers not being able to play on the basketball team, for games getting canceled because too many kids had COVID. For them, that's what matters, which goes to Paul, it's emotional, what matters to you most, because the idea, it's a public health crisis. When you do it, it helps me. When I do it, it helps you. We know that works for some, but not for all.
Yeah, I would jump in here too, and mostly speak as a primary care doctor instead of a health policy person for a minute. And just say, we're down to a much more challenging to reach and convince population, but we shouldn't give up. My own experience is you can get there, but it might take a 20 or 30 minute visit, and it might take 2 or 3 of those. And people will come back for more if you are not judgmental, if you don't make them feel judged by asking questions and having questions, and if you leave the door open to all of the conversation and keep at it. The challenge is how to scale that to a whole country or a whole world. But I would say to all of you listening as healthcare providers, family, friends, others, don't give up. When people feel like you're giving up on them, that's another form of disrespect.
And what I would add to say is that originally I had my concerns actually around the mandates because, as you know, the majority of individuals who experience vaccine hesitancy are African American and originally Hispanics. And particularly in the healthcare sector field, those individuals are also at lower socioeconomic status. So I feel that it would be a double whammy for them because we've been disproportionately impacted by the pandemic, and having to experience economic loss would be another challenge. And also as a physician, I really value the shared decision-making process, but I really understand that there is value in vaccine mandates. And I've seen this actually through our healthcare system because we spent a lot of time and effort providing COVID-19 education to our healthcare workers, either by one-on-one sessions, town halls, providing, emails, et cetera. And we provided, I think it was a 3-month period where people could get vaccinated before the mandate took place. And by the time we reached September 1, which was, I think, the deadline to get vaccinated, 99% of the workforce got vaccinated, which was really encouraging. Now, the uptake wasn't consistent or the same in terms of slope across social and demographic groups. The uptake was a little slower and more rapid at the end for African American healthcare workers. And I know of individuals who got vaccinated, even if they were hesitant, just because of the fear of economic loss. And so I don't think it changed hesitancy. It was just a risk-benefit calculation, and they just decided to get the vaccine. And so I do understand that mandates have values because it definitely increases uptake and reduces the risk of vaccination. But I do think that we have to be careful and continuing to sort of, supporting people and providing a consistent messaging and encouraging vaccination ahead of mandates if possible.
Ayla, do you want to jump in?
Yes. Oh my goodness. what we cannot do, and I had actually taken hesitant out of my vocabulary, and I want to make sure I mention Bloomberg reported Philadelphia, for those who are on here, we have the highest rate of African Americans vaccinated in the nation, in the United States. And I am telling you, I'm raising my hand as a full proponent and taking credit for a lot of that work. And so we just have to be careful because it was the narrative that African Americans and Black and brown people didn't want vaccine that made it hard for me to get vaccine from the city, because they said we don't have a lot, it's allocated to different places, and Black people don't want it. If we give it to you, then we won't have it for the people who want it, and we've got to get the people who want it vaccinated first. And I had to show that people wanted it the first day we opened with 500 people outside, and it was 10 degrees outside, right? So we got to be careful, because even now, as I vaccinated people yesterday and they got their shot, they were like, oh, that's it? Oh, people told me all these stories about what was going to happen and all of that. So I try, and when people come, and I had a pastor get vaccinated who had COVID 12 months after he had COVID. I never asked him why now. I never asked anything. I just said, glad to see you, right? So as we are leaders, be careful with the words we use, because people hear us and then it's, oh, well, if nobody's getting it, then I'm not going to get it, right? And we have to make sure people know that we're higher than anyone else in the nation. And I keep checking, it has not gone down in Philadelphia. And even if I didn't personally vaccinate, I know a lot of people have said, because we listened to what you all were doing, because we heard the consortium, because we saw you, we knew it was okay. And that matters.
I think that language matters a lot. Paul.
Yeah, just to underline what Ala just said, I think, and to make the point again about the importance of emotion, because when you hear it in Ala's voice, I mean, she's very emotional, and I think I'm sure that is a main reason why she's so persuasive. I mean, you can feel it, and I think, you know, when you watch television and see, for example, like there's now 200,000 cases, for example, of childhood infections, or there's another 30% increase, and now we have X number of people who've died. It's the old Stalin line, which is, one death is a tragedy and a million deaths is a statistic. I think, we just sort of numb people with the numbers and have to make it personal and real and intimate. And I think we can do a better job at that.
Let me come back briefly to this sort of misinformation, disinformation, which is it's been such a force here in the US, globally. We're doing some work in South Africa right now with their rollout. And, among the people unvaccinated, which is still a very big group in South Africa, the number one reason we're told in surveys for why I haven't been vaccinated yet is it will kill me. The vaccine will kill me. I will die. And I know someone who died. My cousin died. My friend's cousin died after the vaccine. And that's, we hear lots of different versions of that. Countering misinformation is really, really hard. And I know most of you work in different spaces than sort of health communication and misinformation, but from your area of expertise, what do we need to do? What strategies do we have to, besides trust, we talked about trust, which I think is a big one, but what else do we have to counter the misinformation and disinformation?
Actually, Allison, if you don't mind, I'll take that
Please,
first. So actually, there's data out there showing that misinformation has a negative impact on uptake of COVID-19 vaccine. I mean, we can imagine, we know anecdotally that just by speaking with others that it does, but there's actually data from a randomized control trial of 4,000 individuals in the US and the UK, where they exposed participants to misinformation through social media versus accurate information. And there was a 6% decline of vaccination, of intention to get vaccinated among those who got exposed to misinformation. And if you take that you could say, okay, 6% is not a big difference, but when you multiply and you look at that at a population level, it really can have a significant impact. And I think that's one of the reasons why the US Surgeon General identified misinformation as a public health threat. So I think thinking about multi-level strategies is important. Continuing with consistent and accurate messaging through trusted messengers is important, but I think we really need to be more creative, particularly on the social media world, about combating misinformation, either through providing an accuracy nudge or having sort of an environment where others really sort of identify and flag misinformation. I really think that it's going to take work from public health officials, researchers, behavioral interventionalists to really tackle this.
I think, Allison, I think, might have hit the nail on the head when you said a multi-layered strategy, because there's not a single silver bullet here, and it's going to take strategies at all levels. So to start with, governments can block and shut down the websites of foreign actors who are targeting our populations with misinformation, and particularly they are targeting now Black and Hispanic populations. And we have not seen sufficient action in that regard. We need to do a much better job calling out in the public, those actors, those websites, those organizations who are spreading this misinformation and making it incredibly uncomfortable for them to persist in that. It's right now, I mean, it's at a magnitude that is really, really hard to do it. And then I think we can move forward with you don't want to amplify it, but you can't let pass and let go this information. You can do positive nudges. You can do these other sorts of things, but a positive nudge alone isn't going to do it. I think there have to be strategies and tactics at every layer of this. And again, they're going to be different in different countries. And that's also just a really challenging thing. The other thing that I just want to highlight for a moment about the globalization of this and thinking about the US is we have really large diaspora populations in the US of one kind or another. And to some extent, they can be incredibly effective messengers about countering disinformation in a country where they still have families. It can also work the other way, that they get a lot of misinformation. They can either spread it, or their countries can, or family in those countries who are getting vaccinated can share with their family members here. But I don't think there are a couple of public health emergencies now that we've been through where I don't think we have taken sufficient advantage of how to really positively engage that population for meaningful change. It's easy to figure out who they are. You can put them all on a map because our country is so segregated. You know, you can reach large clusters of people pretty quickly. It's all mapped out, but we haven't yet fully leveraged the potential here. And I'm curious to hear about your experience with that in Philadelphia as well. I mean, I had a patient last week who was Cameroonian, who was absolutely shocked to hear that people in Cameroon were getting vaccinated. And, you know, it was one of those things that finally moved her, checking with her family members in Cameroon, right? Okay, she came back for vaccine, but it's really interesting dynamic.
Yeah.
I was going to say, everyone gave great options, but definitely using yourself as an example. You know, when my twins came to get vaccinated and they're in 6th grade, I posted that all over social media. They posted it as a TikTok. This is how I feel after getting my 2nd shot with this cute little dance, which I didn't promote, by the way, making sure it's barrier free. And I mean, when the person comes in and they don't have a referral, or they have ID, that's their work ID, and you can verify it some way, somehow, don't turn them away, because you might not get them back. When you're about to close and they say, I took 2-3 buses to get here, don't tell them to come tomorrow, let them come in. Then you go to the people you have to go, as you pointed out, Nicole, we know where the rates are lowest. You got to go to them and they're more likely to come, and you're going to have to go more than once, over and over. One of the advantages to being in a church, unfortunately, is you see all the funerals from COVID, and it has been a lot and taken a toll on us. And the pastor will tell you, the husband got vaccinated, the wife did not, we're burying her today. I tell those stories over and over. And now I've gotten so brazen to say, and the ushers all know, make sure they know that we're testing, make sure they know that we're vaccinating, and they come right over from the funeral and they get tested or get vaccinated. Same with the Philadelphia firefighter recently who died from COVID, brought them all over with Commissioner Teal. My kids do basketball, swimming, gymnastics, and track and field. I brought the teams in, had a separate day where just the teams could come. And then if the parents also wanted to get their booster or first shot at the same time, did that. So it was basically every circle that I could touch. That was, you know, my mom's church group, everyone made it easy and accessible. And even for the kids to do it together, for them, made it easier. And then they would bring another friend the next time. And so those are some of the things that were, oh, and most important, for the holidays. All you have to say is, if you want to come to my house for Christmas, you have to be fully vaccinated 2 weeks after your 2nd shot. And people want to be together this year, and to hear that you're saying, listen, I love you, and it's because I love you that I can't let you come in my house and affect grandma and affect, you know, the baby who's too young. That's why you can't come, but I'll go with you to get vaccinated. That matters. And that's how we do it on the individual, very personal level. You'd be surprised how many people you get that way.
Yeah, that really underscores what Nikki said earlier about, you know, at this point, it's a lot of one-on-one, one-by-one, family-by-family solutions. There are great questions in the Q&A, and I want to get to a few of them. Most of them are directed, I think, mostly at one panelist. So I'll send them your way, and maybe pretty crisp responses, so we can have some rapid lightning round at the end. The first, Nikki, for you around COVAX. Is it a good solution? Is it the right mechanism and the right vehicle to address the pandemic globally? Is it working? What's your take on how COVAX is doing?
So I think what I would say is COVAX was put together in the first place because there was no mechanism in the world to buy raw materials, to manufacture vaccines, to convince the companies that if they made it, somebody would buy it, to buy it and to distribute it equitably. So it's put together quickly. It was put together for that reason. It needed to get money from high-income countries to do this. I think we all appreciate the fact that the high-income countries put themselves first in line. And while they talk a good game, have pretty consistently ensured that COVAX can only place orders sort of after that. And then there are some funky things about this. So it hasn't worked perfectly, but it has worked pretty well. And like everybody else has been slow to get vaccines out, COVAX has been a little slow, but they're going to get close to a billion doses out by the end of this year or really, really early in 2022. And that's pretty amazing. I think what's really important is to look on the other side of this and say, what needs to be fixed so this never happens again? Do you need a mechanism that's like COVAX? Absolutely. Do you need equitable access commitments? Yes. Do you need financing? Yes. You can't be passing the tin cup in the middle of a pandemic. That's like probably what I said a year ago. I still believe that today. And so I'm a pretty strong believer in these global organizations coming together, standing up and saying, I got responsibility for doing this. This is my job and I'm going to do it. And the world needs to be able to count on that and support it. I also just want to say that all parties, though, have a role in this. And I don't think it absolves any country, number one, or any manufacturer, number two, from participating in the system. And I think as COVAX has gone on, we've seen more and more the manufacturers be willing to provide, either not-for-profit or lower cost or tiered pricing to COVAX. I think we're in a situation right now, and I just want to call this out with Omicron, where COVAX is up and running. It's working. It is allocating and distributing vaccine. But still, right this minute, high-income countries are making deals with the companies that can rapidly adapt a vaccine to a new variant. Most of the people in those countries are already vaccinated, and they're going to do just fine without another Omicron adapted vaccine right now, I think. And I personally would like to see those companies that didn't necessarily take much risk at the beginning of this step up now and say, we're going to take some risk. We're adapting this vaccine. We're going to take the first 100 million doses and allocate it to COVAX. We know we don't have an order yet because of all the funky ways in which it works, but we're going to step up because we understand that in addition to making and selling vaccine, we have a global public health and moral obligation to help end this pandemic.
Some interesting feedback loops, again, just back because this South Africa survey data is top of mind for me. Another reason people are saying that they're going to wait on vaccination is they want the finished one. They want the final one that will work against all variants. I don't want to get this like intermediate one. So they know that this
maybe 5 or 10 years from now, we'll be there. But exactly. We're not going to be there, and it should be a goal, and we should work toward that. And we're not on target to do that in this pandemic. So my message to everybody right now is get vaccinated with what you can get vaccinated with. I'm not sure people in most of the developed world, what people have had 2 or 3 vaccines, need a variant adapted vaccine. If in fact this continues, when a variant adapted vaccine is available, let's kind of slot it in instead of what's there. But let's please, developing world, let's not dump all the vaccine you don't want on low and middle income countries.
Paul, a quick question to you around your stance on boosters. Sage Myers is saying, if boosters would help decrease spread, wouldn't that be a good thing for everybody to get a booster just for the sort of drop in R naught or RE, I guess?
Unmuted. So what do you know? You know that from studies in Singapore and elsewhere that if you've gotten, say, 2 doses of an mRNA containing vaccine and you have mild illness, as compared to if you're unvaccinated and you have a mild illness, you will shed less virus for less long if you've been vaccinated. So that's true. So then the question, because so it's a good point. I mean, if you've gotten a 3rd dose, isn't it also true that you will shed even less virus over a shorter period of time? Yes, I think that is true. The question is, what kind of an impact is that going to have on this pandemic? And I think if we had, as Israel has, for example, 90% of the population vaccinated, I think that would make a difference. But we don't have that. What we have is more like 70% of the population vaccinated. So what's going on now is most of the transmission, most of the spread, most of the contagiousness is occurring in the unvaccinated population. That's what we're seeing, certainly what we're seeing in the hospital. So I'm not sure what impact that's going to have on the 70% who are already vaccinated. And in fact, the CDC basically said that. In the most recent ACIP meeting, one of the working group bullet points was, it is unclear to what extent there's going to be community impact with this boosting the already vaccinated. So I don't think it hurts. I just don't know whether it's really going to make much of a difference. I guess we'll see.
Thanks. Ayla, did you want to take Marion Leary's question about teens consenting for their own vaccines? Just a totally different topic, but.
Sorry. Absolutely. I was trying to type it because I was so excited. Yes, send them all to me. They do not need their parents' consent. And like I said, the kids walk over from Dobbins and I take my time and talk to them. I mean, remember, I'm a pediatric surgeon. So, I talk to them. I tell them what to expect. I've had some kids that didn't want to get vaccinated because they were afraid someone would find out, but they really wanted to get the shot. And I said, you don't have to tell anybody you got it. You can hide your card somewhere. You could take a picture and rip your card out. Oh, really? Yeah, really. And they, get vaccinated. They come together, in the beginning, before it was known you could, they'd say, do I have to call my mom? Now, this is a kid, 14-year-old, that took a bus from, Southwest Philly to North Philly to got there, stood in line and came up to me, but I have to call their parent. Like, they understand. And I go through all the questions still. I ask them about allergies. I ask them about previous things. And of course, we watch the kids. We've got EMTs and we watch them, and for the full, probably longer than 15 minutes. But in Philadelphia, over the age of 12, and Paul, you might correct me, I think it's 11, but I'm going to say 12 because I got to double check that. You do not need consent from your parent. We are at 2001 West Lehigh Avenue. We're actually vaccinating today until 4 o'clock, and we will vaccinate the children. Yes.
You raise a great broader policy point there, Ayla, and that those laws vary across jurisdictions, across states. A 14-year-old or a 16-year-old or a 12-year-old would encounter a different answer to that question depending on what state they're in, which can really facilitate or hinder vaccine take-up in that population.
That is true. But if they come to us, all I need is your name and your date of birth.
I just want to point out, Ayla's also been really diligent in answering some of the questions typed in the Q&A, and also those of you who have asked for some of the resources that have been mentioned, those links are getting dropped in as answered questions in the Q&A as well, and thanks for those requests. I want to move towards wrapping up because the clock is telling us we need to do that. And for Nikki and Paul, who were with us a year ago, we did ask you if, we said a year ago, if we ask you a year from now, what you hope we have been accomplished, where you hope we'll be, and you gave us answers. We're going to read those answers back to you from a year ago, and you can tell us if your vision has been met. So Paul, you said, I hope that we will be able to vaccinate roughly 2/3 of the population and get this virus under control. Did we do it?
Yeah, we did it, but we didn't get it under control. So I think what I am surprised by, I guess, is that I didn't realize you were going to hold me to actually what I said, a year later.
You just thought of this 15 minutes ago. So
here's what I would say. I think the viruses have mutated to the point of greater contagiousness. So the Delta variant is estimated to have a contagiousness index of 5 to 9. When you try and figure out what percentage of the population needs to be vaccinated in order to induce herd immunity or create herd immunity, it depends on 2 factors. One is the contagiousness of the virus, and 2 is the effectiveness of the vaccine. The vaccine's highly effective. So that's good. It's not as highly effective against contagiousness. It's highly effective against protection against serious disease, not as highly effective against contagiousness. And R naught of 5 to 9 is very high. So I do think that we're going to have to have herd immunity, which includes both natural infection or immunization or both, is probably something in the low to mid 90% range. I mean, I feel like this is getting close to measles, even though the measles R naught is closer to 18 to 20. I think we're going to have, I think what we've learned is we have to have a higher percentage. It's interesting to watch Israel, which now is about 90%, like 89.5%. In terms of the population vaccinated, and now they have, they sort of insist on a booster dose. I think you're starting to see evidence of herd immunity in Israel. So I think maybe that's the answer, 90+%. So I wasn't wrong. So I think the point is, don't listen to me. I'm invariably going to.
Fair enough. Nikki, you endorsed Paul's answer, but also said that you hope to be able to say that we've met our equity goals. How do you think we did?
So I think we're on a path, but sadly, I don't know that we've met our equity goals either here domestically, and certainly we haven't met them globally. We have a really, really long way to go, as I think everybody knows, for many parts of the developing world and even middle-income countries to get vaccination rates way up. And for those of you who didn't see it, some really great interactive pieces in yesterday's New York Times making those issues really, really clear. And I think, as I said a couple of minutes ago, I think a lot of this still is on high-income countries and on vaccine nationalism and on inadequate funding and inadequate decisions. And we've got the vaccines out there. We know they're safe. We know they work. When we started this a year ago, we weren't so sure about all that. But the equity remains somewhat elusive.
Elusive is a good word. So Ayla and Florence, we didn't have you a year ago, but we have you today. So when we have you back a year from now in December 2022, what would you like to be able to say that we did in 2022 around the vaccine rollout?
I'd like to say, for me, the November 3rd opening the Center for Health Equity, because I got to a point that so many people were coming to us and I was literally just putting a Band-Aid on after their vaccine, and said, this is a prime opportunity to do a quick checkup, to go over your medications, to ask for screening about cancer, to ask about your mental health. I mean, if I could tell you the number of people I see with a blood pressure of a 250 over 125, okay, that then, we talk about, well, did you take your medication? Well, I don't like how it makes me feel, but using this as an opportunity, since this is a community, we know that there are health disparities and the outcomes are poor, that when they're coming in, it's not just for the shot. And that's what we're doing now. And I hope to be even more a year from now. The other thing is that prayerfully, there won't be another one of these, but if and when they are, and the money starts rolling out and it goes to the usual folks that always get the money, that there's checks and balances, that you may not allocate all of it in the beginning, presuming it's going to the most vulnerable, because unfortunately that didn't happen. And those of us, including myself, who could get a vaccine from whomever I wanted, wherever I wanted, would have had access whether I got CARES funding or not as an insured patient, right? But for many that needed it the most, they were coming to me, which did not get funding from federal funds and state funds and all of those things. So I would just be very cautious, I would say, to all the bureaucratic folks out there that allocate funds when there's a crisis to the same folks, assuming that it's going to get to the folks who are most vulnerable, because it doesn't always happen. And I think if we could learn from this experience, it would be, as we're rolling it out to the folks that want it immediately, you're putting as much, if not more, emphasis on those most vulnerable communities that are most impacted, because that's where more resources are going to have to go to take care of them because they got left behind.
Thanks. And Florence, where should we be a year from now?
So what I would say is, well, first of all, I have to say that this pandemic humbles everyone because it moves such in a rapid pace and it's so hard to predict. But what I would hope, because I was born and raised in Haiti, and issues of equity in the US, but also globally are very dear to my heart. And I would certainly hope that our global response would be better than what it is right now. I do think that we have to continue being intentional around addressing disparities, both here in the US, but also globally, and addressing issues related to costs or decreased access to low-income countries.
Can I say one other thing that
Please, Nikki.
I think Paul would say if given the chance to? A year from now, I hope that all of these parents who haven't gotten their kids vaccinated for routine childhood illnesses have managed to come and get themselves vaccinated, get their kids vaccinated. We got a lot of catching up to do, or we're going to have a huge measles or other kind of epidemic on our hands, and it's going to compound the situation. So it's not just about COVID vaccines here.
That's very true. And, you know, everything you all have said today has resonated with me as a researcher, and many, I think, attendees on the webinar are probably researchers also. The number of research questions you have teed up for us is impressive. You know, to your point, Nikki, I'm quite worried. I study vaccine acceptance for the childhood schedule. I'm worried about kind of spillover of vaccine hesitancy to the childhood schedule, and also at the policy level, potential attempts to maybe roll back our school entry mandates, which, you know, undergird our herd immunity against these diseases. But I think, you know, we've raised questions about how to study equity and equitable rollout and the surveillance that has to happen, but also the policy, obviously all the epidemiological questions about how this variant is spreading, and you know, are boosters and vaccines effective, how we're doing globally, the efficiency of getting these vaccines out, and all the social and behavioral research that needs to happen around persuasion, as well as access and misinformation. There's no end of important questions for us to ask and answer in the coming years. Thank you to our panelists. Let me hand it back to Rachel to close. This was a wonderful conversation. Thank you.
Thank you, Allison, and thank you to all the panelists. I will echo Allison saying this really was a wonderful conversation, and we are very appreciative of you taking the time to spend this hour with us. I also want to thank the audience for tuning in, and let everyone know that this is a wrap for LDI for 2021. And I hope that you will join us next year in 2022 when we have another lineup of seminars. And in the meantime, please stay safe over the holidays, and everybody have a happy holiday. Thanks, everyone.